Good afternoon. I am Dr. Amr Hassan, Assistant Professor of Obstetrics and Gynecology at University. It's a pleasure for me today to be with you. We'll talk about pregnancy risk factors. First, we'll start by story of homocysteine in obstetrics and gynecology. Homocysteine is sulfur amino acid present in body derived from methionine. Methionine is essential amino acid present in large amounts in protein from animal sources like meat, eggs, and milk. Methionine can be stored in liver, and it is demethylated to homocysteine for storage until needed. If there are adequate levels of vitamin B12 and folic acid in body, homocysteine is broken down in harmless waste products. But if there is deficiency of these vitamins, the homocysteine begins its damage on blood vessels. So if a person ingests large lot of protein and there is not enough folate and vitamin B12 to digest it, it can cause hyperhomocysteinemia. If folic and B12 level rise, it decreases homocysteine level. In early 1960, several inborn errors of metabolism were described in young children, leading to extremely high levels of homocysteine, resulting in mental retardation and early deaths. In early 1990, elevated homocysteine was being considered as an independent risk factor for cardiovascular disease. Methylation of homocysteine to form methionine requires methyl group from methyl tetrahydrofolate and vitamin B12 as cofactor. Causes of hyperhomocysteinemia. General causes like increased age, male gender, menopause, lifestyle like smoking, high coffee consumption, and alcohol consumption. May be related to diet like low fruit and vegetable intake, high intake of methionine containing proteins, and low intake of folic acid and vitamin B12. Disease like chronic disease, chronic renal disease, diabetes, hypothyroidism, and certain malignancies and malabsorption syndrome. Since vitamin B12 and folic acid catalyze remethylation of homocysteine to methionine, therefore hyperhomocysteinemia may be caused by deficiency of folate or cobalamin vitamin B12. There is direct relation between pregnancy, homocysteine, vitamin B12, and folate level. As we see, women in different gestation, they have gradual increase in homocysteine level, while there is gradual decrease in level of folate and vitamin B12 through the journey of pregnancy. It's risk factor for many pregnancy complications. 20% of pregnant women are at risk of different pregnancy complications due to high homocysteine level in pregnancy. 2 to 10% from pregnant women are at risk. In many individuals with inborn error of homocysteine metabolism, kidney or liver disease, ingestion of some pharmaceutical, homocysteine level can rise beyond normal level and lead to adverse health outcomes like early pregnancy loss, neural tube defect, placental vasculopathy, cardiac malformation, preeclampsia, placental abruption, low birth weight, and congenital birth defects. There are a group of disorders that arise in early in fetal development, can cause lifelong lasting complications of varying severity. Sometimes neural tube doesn't develop normally, which may affect brain, spinal cord, and meninges. This neural tube fusing process is complete by 28 days of gestation, before many women even know they are pregnant. Symptoms of brain or spinal cord damage may develop. This defect affects brain or spinal cord tissue. Brain damage can be fatal or may result into mild or severe disability. Spinal cord damage can result in paralysis, incontinence, loss of sensation, areas of body reached by nerves below level of defect. As this picture to show the normal and encephaly and the spina bifida. I will discuss cranial presentations which may be caused by hyperhomocysteinemia. Anencephaly, which is congenital abscess of cranial vault with cerebral hemispheres completely missing or reduced to small mass attached to base of skull. Or encephalocele, which is hernia of part of brain meninges through skull defect. It may be congenital, traumatic, or post-operative in origin. While spinal presentation like spina bifida, which is the most common neural tube defect. It occurs when a spine fails to close properly due to first weeks of pregnancy, causing damage to nerves and spinal cord. Types of spina bifida occur as the mildest form, in which is a small gap or malformation, or meningocele or myelomeningocele. It will also cause threatening miscarriage. 3.6% of pregnant women are at risk of miscarriage due to hyperhomocysteine, as well as vitamin B12 and folate deficiency. Threatening miscarriage represent 18% from pregnancy complications due to hyperhomocysteinemia. Also, it may cause preeclampsia, where 8% of patients are at risk of preeclampsia due to hyperhomocysteinemia. Preeclampsia represent 41% from pregnancy complications. So prevention is better than cure. So when we are talking about combination of vitamin B12 and folic acid can maximize the reduction of homocysteines and folic acid when used alone. If you want to talk about vitamin B12, it's water-soluble vitamin, which is stored in liver, is collective term for group of cobalt-containing compounds, principal cobalamin, arsenocobalamin, mecobalamin, hydroxycobalamin, and 2 coenzymes forms of vitamin B12. Vitamin B12 combines with substance called gastric intrinsic factors. These complexes can be absorbed by intestinal mucosa. Intrinsic factor is secreted by stomach mucosa. It tightly binds with vitamin B12 and helps its absorption. Mecobalamin is the only form of vitamin B12 that can be absorbed from intestine either passively or bound to intrinsic factor. Vitamin B12 is needed for normal cell activity and DNA replication. Vitamin B12 and folic acid regulate formation of RBCs, so are essential for production of DNA and RNA. Folic acid and vitamin B12 works to increase activity of methionine synthase enzyme, preventing occurrence of hyperhomocysteinemia. Second risk is iron deficiency anemia. When talking here about elemental iron, which is ferric, which here for smart iron absorption. As when it's ferric, upon deficiency, ferric is reduced to ferrous by duodenal cytochrome. Ferrous is transported by divalent iron transported into the thyrocyte. So there is no passive diffusion. Since there is no passive diffusion, no overdose is expected. So now we are talking about smart iron absorption. So it will decrease expected side effects. Non-transferrin bound iron is the most toxic iron forms. So hemaltose, which is a kind of ferric iron, no increase in non-transferrin bound iron, which was observed after administration of 150 milligram of ferric iron compared to 4-fold increase in iron gluconate and 6-fold increase to iron glycine sulfate and 8-fold increase in iron sulfate. We are talking about it is well tolerated with limited potential for side effects. As we said, hemaltose, which is ferric, show fewer side effects compared to ferrous sulfate. Last risk factor was started before pregnancy, which is PCO, which can affect occurrence of pregnancy. PCO, as all we know, is one of the most common reasons for infertility. 50% of patients of PCO suffers from obesity, and there is correlation between plasma concentration of L-Carnitine and patients and BMI. So L-Carnitine has significant reduction of BMI and weight. Carnitol plus L-Carnitine and zinc improves insulin sensitivity. So when we're talking about L-Carnitine plus zinc, it improves insulin sensitivity, which in turn affects androgen and ovarian hormone level. The effect of L-Carnitine in Pco-Infertile patient lead to growth of dominant follicles, rise in mean thickness of endometrium, which helps to achieve pregnancy. As this paper talking about potential role of carnitine in patients with PCO, a systematic review, which shows that increased rate of ovulation. So carnitine plus zinc improve quality of ovulation, improves pregnancy rate. In women with PCO, zinc supplementation has positive effect on many parameters, especially related to insulin resistance and lipid balance. Zinc supplementation seems to improve PCO symptoms, particularly among women with insulin resistance and lipid balance. Reduced level of zinc in PCO, accompanied by impaired hormonal lipid and glucose metabolism, and increased concentration of sedative stress markers. So we are talking about to use L-Carnitine and zinc to treat PCO. Its benefits: improve quality of ovulation, increase pregnancy rate, enhance lipid profile, and BMI. Thank you.